Plantar heel pain, pain under the heel, can be caused by many different tissue sources of nociception. In most cases, it's the medial band of the plantar fascia that is overloaded as it inserts onto the inner part of the heel bone. However, there are other important problems that can occur, including a stress fracture or bone bruising of the heel bone. Sometimes there's even entrapment of the inferior branch of the lateral plantar nerve, and this can create more burning pain, and even bruising and inflammation of the fat pad can also cause a bruised sensation under the heel. So it's not that simple. This area of the body takes an enormous amount of tensile and compressive load, so it doesn't take much to develop problems here. Plantar fasciitis is more correctly termed plantar fasciosis or fasciopathy because it's not classically an inflammatory problem, even though some inflammatory chemicals are present in the tissue. It is a very common presentation to a sports physician because surgery is really an absolute last resort, and conservative management and time are usually effective. The duration of symptoms can be anywhere from months to years, but in most cases, the symptoms do resolve with treatment. Risk factors. Plantar fasciosis usually comes on quite insidiously, and patients often notice the sharpest pain on the underside of the heel with the first few steps of the morning. Sometimes there's also throbbing pain by the end of the day, especially in patients who work on their feet. And this is your usual profile: the overweight middle-aged patient who's really trying hard to get back into shape and suddenly upgrading their exercise intensity and loading. Now clearly, mechanical overload is an issue for patients who are on their feet for long periods of time, or who have unsupported footwear or a very vertical heel shape and a rigid heel. But metabolic health also seems to be important, with diabetic patients having a much higher risk. The thickness of someone's plantar fascia has been found to correlate with their long-term blood glucose control, particularly in type 1 diabetics. And this is thought to be linked to the formation of advanced glycation end products, or AGEs, which disrupt normal protein and collagen function. The diagnosis of plantar fasciopathy is usually straightforward, with pain being reproduced by direct pressure on the medial part of the heel, the medial calcaneal tuberosity. The clinical assessment of the painful plantar heel should aim to exclude two important differentials, especially in patients with an atypical history. Squeezing the heel from both sides with your palms can help exclude a stress fracture, for example in a runner or someone who's suddenly increased their impactivity a lot. And tapping the inside of the ankle to determine whether there are any symptoms reproduced can help exclude nerve entrapment. The pain of plantar fasciopathy can be described as burning, so this doesn't necessarily mean there is a nerve problem. There are so many things that can be done to target the structure and function of the plantar fascia, as well as the patient's pain. And each treatment might help a little more, but treatment generally should be targeted individually to each patient. The most important thing to realise in the management of plantar fasciitis is that the plantar fascia behaves much like a tendon, and histologically, it has a very high proportion of type 1 collagen fibres. It tightens up and stiffens as the foot and the great toe extends, which helps us to generate power as we toe off. So, in addition to weight loss, this means we really should be treating plantar fasciopathy using progressive strengthening and exercises that model its function. And that's exactly what Michael Rathleff and his researchers have done. They used a progressive strength program with modified calf raises targeting the plantar fascia and windlass mechanism by pulling the toe up with a towel. And they found this to be superior to plantar fascia stretches alone at 3 months. Sports physiotherapists are very in tune and skillful at identifying and addressing kinetic chain contributors such as poor ankle, hip, or even great toe range of motion that can make the windlass mechanism inefficient and overload the plantar fascia. Now down the bottom of the checklist, there are more invasive options that might include things like shockwave therapy, corticosteroid injections and platelet-rich plasma injections. And these treatments are for pain. They should always be in conjunction with rehabilitation exercises, which are more likely to alter tissue structure in the long term. Because patients have often tried many things, I do think it's useful to use a checklist to work out what you've used and what you've missed. This is my checklist for the comprehensive management of plantar fasciosis, all of which have some level of clinical evidence. The first aspect of management is activity modification to reduce the compressive and tensile loads on the plantar fascia. In patients who have pain when walking, alternative activities that don't stress the plantar fascia include cycling and swimming. In patients with severe pain and an inability to rest, a walking boot can be a useful adjunct, but only with short-term use to offset ankle stiffness as a complication. Footwear and orthotic optimization is an essential part of management, and a Strasbourg sock can be a very effective tool in reducing early morning waking pain. Metabolic health and weight optimization is a critical aspect to load management, but also some of the effects on the tissue health itself. As discussed, a combination of strengthening and lengthening exercises can assist with remodeling of the tissue and reduction in sensitivity. In patients who have had ongoing symptoms for about 6 to 12 months, it is a reasonable decision to go forward with advanced imaging, which would include an MRI. Further adjunctive treatments for pain and inflammation can include a short course of non-steroidal anti-inflammatories, physical modalities such as massage, acupuncture, and shockwave therapy, shown in the image here, and ultrasound-guided injections, including corticosteroid when there is a bias toward inflammation around the tendon, versus platelet-rich plasma when there is evidence of tissue injury, such as a partial thickness tear. Obviously, all of this needs to be individualized to the patient.
I hope you found this video useful. I create these educational videos to help empower patients by allowing them to understand their problem, treatment options, and the expected recovery. Please remember, this lecture is for educational purposes only, does not constitute the giving of medical advice, and no patient-doctor relationship is formed.
For their effectiveness.